So, good evening once again, and I hope that everybody would enjoy this lecture tonight on nutraceuticals, which is rarely discussed in migraine prophylaxis. We know that there are a lot of supplements right now in the market. It may be in the form of herbal supplements, vitamins, and other nutritional products with physiologic benefit. So for tonight, at the end of this session, we want everybody to know the evidence supporting the use of nutraceuticals, specifically magnesium, riboflavin, and coenzyme Q10 in migraine prophylaxis, to discern the mode of action of these commonly used nutraceuticals in the pathophysiology of migraine, and to utilize these nutraceuticals with confidence for migraine prophylaxis. Migraine is now an epidemic. It affects 1 billion people on the planet, approximately 12% of adults. Migraine remains the second among the world's cause of disability and first among young women based on the findings from the Global Burden of Disease in 2019. About 18% of adult women and 6% of men meet the criteria for migraine. Migraine can actually start during childhood with a peak incidence of 7 years among boys and 10 years among girls. However, we know that in adolescence and onwards to adulthood, it becomes more frequent with higher incidence among women. It is most prevalent among people in their 30s or and up to the 40s, which is their reproductive age. So it affects all aspects of their life, specifically their work, school, and even their family relationships and personal and leisure time. Migraine is a hyperexcitable brain which can activate. Sorry, I'll just hide the controls. So migraine can activate your trigeminal system in genetically susceptible individuals. And the triggers may include the following: hormones, lack of sleep, stress, exertion. The trigeminal vascular system can be activated by the cortical spreading depression and the peripheral activation of the sensitized receptors all over the body. Nociceptive transmission originates from activation and sensitization of your first order trigeminal vascular neurons. Their cell bodies are in the trigeminal ganglion, and their afferent fibers innervate the meninges and its vessels. And then ascending nociceptive transmission from the trigeminal ganglion is projected to the brainstem, activating your second order trigeminal vascular neurons, including those in the spinal trigeminal nucleus. This in turn would activate your third order trigeminal vascular neurons in the thalamus, which would relay the nociceptive transmission to your cortex, specifically your somatosensory cortex and other parts like your prefrontal cortex. Studies have shown that activation of the trigeminal vascular system results in parasympathetic outflow to the intracranial arteries, including the dural arteries, through the superior salivatory nucleus and the sphenopalatine ganglion. This outflow would in turn lead to dilatation of the intracranial arteries due to release of signaling molecules such as your pituitary adenylate cyclase activating peptide or your PACA and vasoactive intestinal polypeptide. Furthermore, it also results in antidromic release of vasoactive signaling molecules such as your calcitonin gene-related peptide or your CGRP. And this would contribute to dilatation of your intracranial arteries. Imaging studies have helped us understand the pathophysiology of migraine. So you can have four phases. The premonitory phase, wherein patients would feel tired or may manifest with yawning, poor concentration, mood changes, neck discomfort, and polyuria and other signs and symptoms. Then some patients, for those patients with migraine with aura, would have the aura in the form of visual, somatosensory, or brainstem aura. And then this will be followed by the headache phase, wherein other accompanying symptoms are your nausea, vomiting, photophobia, and phonophobia. However, there is still a post-stromal phase, no, which is when the patients would still feel tired with poor concentration and other body pains. So it would sometimes take a few days, no, which is very debilitating for the patients. PET scans have showed that during the premonitory phase, there is activation of the posterolateral hypothalamus, the midbrain tegmental area, the periaqueductal gray, the dorsal pons, and the occipital temporal, as well as the prefrontal lobes. During the aura phase, hypoperfusion would result in cortical spreading depression. This, according to Liao, is an intense depolarization of neuronal and glial membranes accompanied by a massive disruption of ionic regions and loss of membrane resistance. Visual auras have been documented with decreased blood flow in the occipital lobe. During the headache phase, there is activation of your meningeal nociceptors, which releases your CGRP, neuropeptide P, neurokinin A, and glutamate, resulting in vasodilatation. Central sensory sensitization plays a key role for the cephalic and extracephalic allodynia, which may become persistent. Peripheral sensitization, wherein peripheral trigeminal vascular neurons become sensitized to neural stimuli and is responsible for the characteristic throbbing pain in migraine. And these inflammatory changes may persist during the post-stromal phase, causing the signs and symptoms that are seen in our patients. So there are different types of migraine, as we all know, and the most common would be the migraine without aura and migraine with aura. So just as a review for patients with migraine with aura, before we diagnose them, we should at least document 5 attacks fulfilling the characteristics of a migraine headache. The headache should last for 4 to 72 hours, and in children, it can be as short as 2 hours. The headache should have more than two of the following characteristics: unilateral in location, pulsating quality, moderate or severe pain intensity, and aggravated with physical activity. During the headache, they should have more than or equal one of the following: nausea and or vomiting, and photophobia and phonophobia. So the difference for migraine with aura is that the patients would have aura, and it can manifest with visual, sensory, speech disturbances, motor symptoms, brainstem, or retinal symptoms. And the headache would have the same character as in migraine without aura. Now, this is another fast way of diagnosing migraine, which is the PIN, PIN the diagnosis, P for photophobia, I for impairment, and N for nausea. So they say that 2 out of the 3 symptoms would give you a 93% positive predictive value, and 3 out of the 3 symptoms would give you 98% positive predictive value. Other associated features of migraine, which are not usually mentioned, are osmophobia, which is highly specific for migraine, and a sense of restlessness or agitation, which is more commonly seen in trigeminal autonomic cephalalgias. Migraine can be episodic or chronic. And when we say episodic migraine, these are patients with less than 15 headache migraine days per month, while chronic migraine are patients with more than or equal to 15 migraine days per month. So there are patients who develop chronic migraine, and it is said that around 2.5% of patients with episodic migraine can develop chronic migraine. And these are the risk factors for progression from episodic to chronic migraine. We have the non modifiable risk factors, and as you know, female patients have a higher incidence of migraine, and other factors like marital status, socioeconomic standing, and education have actually inconclusive associations. And the role of genetic influence on the progression of episodic to chronic migraine remains to be elucidated. Modifiable factors which can provide targets for intervention, including lifestyle factors, headache features, and comorbidities. High caffeine use, obesity, and poor sleep quality and sleep disorders were seen in patients with chronic migraine. The more often reported comorbidities in chronic migraine patients are psychiatric disorders, head and neck injuries, cardiovascular disease, metabolic syndrome, asthma, sleep apnea, and other pain syndromes. Patients with increased headache frequency of 3 times per month with cutaneous allodynia and medication disuse can also have risk factors for developing chronic migraine. Migraine prevention, however, remains to be underutilized. In the study by Lipton, wherein self-administered headache questionnaire was mailed to 120,000 US households, they noted that around 38.8% of candidates should receive preventive treatment, but only 12.4% were receiving prophylaxis during the survey, or 1 in 4 migraine patients are actually candidates for preventive therapy, but a substantial portion of these patients do not receive prophylactic medications. There's actually a local study also which showed the same results. We currently tend to add preventive therapy when attack frequency or impact and disability are very high. But there are some patients with infrequent attacks, yet with significant disability, and they would benefit actually from preventive treatment. From the American Headache Society 2021, preventive treatment should be considered in the following situations. Patients with migraine attacks of more than or equal to 4 attacks per month or once per week should be considered, and or the attacks are interfering with the patient's daily routines even with acute treatment, or if there are contraindications, failure, or overuse and adverse events with acute treatment, patient preference. And then we mentioned also that medication overuse and chronic daily headaches uh, of patients have elevated risk. We mentioned uncommon subtypes of migraine patients are also candidates for preventive therapy. Patients with hemiplegic migraine, brainstem migraine, prolonged aura, and especially migrainous infarction. So the goals of migraine prevention is as follows. We have adherence is compromised, usually due to cost, side effects, or sometimes patient refusal to take maintenance medications. So this can be improved by adding behavioral approaches. Sorry. For the goals of migraine prevention, we want to decrease migraine days, headache days, the intensity of the symptoms, the duration of attacks, and prevent disability. We want to reduce the reliance on poorly tolerated, ineffective, or unwanted acute treatments, reduce the overall costs associated with migraine treatment, and enable patients to manage their own disease to enhance a sense of personal control. And we want to improve their quality of life, and this can be measured with your health related quality of life or your HRQOL. However, we know that benefits with migraine prophylaxis can occur over time since the effects are not usually seen, no, with a few weeks or just 1 month of treatment. There are actually four issues affecting current preventive therapy. Adherence is also a problem because of the cost, the side effects of the more common prophylactic medications, and sometimes the patient's refusal to take maintenance drug. And this can be improved with other behavioral therapies. As preventive drugs are not specific to migraine, they are associated with various events. The medications also must be taken for at least 2 to 3 months before that we say that there is prophylactic failure. It is important to set realistic expectations and inform patients adequately about what to expect with the common prophylactic medications and its adverse events. And they should be advised to inform their doctor for possible side effects and not just stop the drug abruptly. Some of our patients would just stop the drugs after 2 to 3 days and they would follow up the following month. No? So we do not see the effect of these prophylactic medications. Currently, there are a lot of preventive medications for migraine, although you would know that these are not actually purposive drugs no, for migraine, but were actually developed for other indications. Based on the AAN and AHA guidelines, the following medications are established as effective and has level A recommendations. So for anti-seizure medications, we have divalproate sodium, sodium valproate, and topiramate with level A recommendation. For the beta blockers, your propranolol, metoprolol, and timolol. And for the triptans, actually provatriptan is the one with level A recommendation as prophylaxis, while the others are also used as acute treatment. And for level B recommendations, antidepressants like amitriptyline and venlafaxine, beta blockers atenolol and nadolol, and the triptans naratriptan and zolmitriptan have level B recommendations. In choosing the right prophylactic medications for our migraine patients, we must also consider their other medical conditions or comorbidities. So for patients with concomitant depression, we can give your tricyclic antidepressants. For patients with weight problems, we can give them topiramate. And as you know, the other anti-seizure medication, valproate, is known to produce weight gain in our patients. So most of our women patients would refer to pyramid. For hypertensive patients, we can give our beta blockers or calcium channel blockers. And of course, the other prophylactic medications with lesser side effects are your nutraceuticals, your magnesium, riboflavin, and coenzyme Q10, among others. The mechanisms of action of these prophylactic medications also vary since, as I have mentioned earlier, they were not really developed for migraine. So methysergide is a serotonin antagonist which acts specifically on your 5-HT2 receptor. Flunarizine is actually the most studied calcium channel blocker. It is a non-selective calcium antagonist which has been shown to block voltage-gated sodium channels. The beta blockers modulate central neurotransmitters. Specifically, they inhibit the beta 1 mediated effects like inhibition of noradrenaline release and tyrosine hydroxyl activity. They also regulate the firing rate of the periapical gray matter neurons via your GABA mediated action. Propranolol reduces neuronal firing rate of the noradrenergic neurons in the locus coeruleus and interferes with central sensitization. Valproic acid and gabapentin enhances your GABAergic inhibition in migraine prophylaxis. Another notable mechanism is alteration of neuronal oxidative metabolism by riboflavin and reduction of neuronal hyperexcitability by magnesium replacement. So the treatment principles in migraine prophylaxis is we have to start with the low dose and titrate slowly until we reach a therapeutic dose. allow for an adequate treatment trial duration, which is more or less 2 to 3 months, choose treatment based on comorbidity of the patient, establish expectations of therapeutic response and adverse events. We can quantify and monitor the effects using common migraine scales like your MIDAS, your HIT6, or your HRQOL. We should reevaluate treatment at regular intervals and maximize adherence of the patient, and patient buy-in is actually essential. Studies revealed that there are decreased levels of micronutrients, riboflavin, magnesium, and coenzyme in the plasma and brain of migraine patients. These micronutrients play an important role in the production of energy in the mitochondria. A deficit of mitochondrial energy metabolism may play a role in migraine pathogenesis. We know, for example, that migraine can be a prominent feature in patients with MELAS. Thus, knowing that mitochondrial dysfunction is associated with migraine, this supplement, specifically riboflavin, magnesium, histamine, and coenzyme Q10, feverfew, and butterbur, may have a role in migraine prophylaxis. So I'll just mention butterbur in passing, like your feverfew. These are actually herbs, and butterbur is a shrub, and it contains a family of compounds called betacins, which have anti-inflammatory and anti-spasm effects on blood vessels, no, and even the cerebral blood vessels. So in a double-blind placebo-controlled trial by Grossman, 50 milligrams of a standardized extract of pesticides was given twice a day, resulting in a statistically significant decrease in the frequency and pain intensity of migraine. So the American Academy of Neurology actually gave it a level A recommendation, while the Canadian Headache Society gave it a strong recommendation with moderate quality evidence, and the European Federation of Neurological Societies rated it as a prophylaxis of third choice with level C evidence. However, we must remember that butterbur contains your pyrrolizidine alkaloid, or the PAs, which were shown to have hepatotoxic, mutagenic, and even carcinogenic properties. Thus, it has been pulled out from the market in some countries like Germany, but it is still available in the US, and you can actually find it in the online stores. The next is your oral magnesium. Magnesium is a cofactor in more than 300 enzyme systems that regulate diverse biochemical reactions such as protein synthesis, energy production, and muscle and nerve function. It also has a role in blood glucose and blood pressure control. As you know, our OB friends used the IV magnesium for preeclampsia. Magnesium is required for energy production, oxidative phosphorylation, and glycolysis. Magnesium homeostasis is controlled by the kidney, and renal failure may lead to magnesium toxicity. There are actually three RCTs, which I will be discussing later on magnesium for migraine prophylaxis. There is abundant magnesium in the body, and it is also present in foods. An adult body contains approximately 25 grams of magnesium, with 50 to 60% present in the body and soft tissues. It is also widely distributed in plant and animal foods and in beverages. Green leafy vegetables such as spinach, legumes, nuts, seeds, and whole grains are good sources. And you can also find this in dark chocolate, avocados, and some fatty fish and bananas. Adult RDA for men is 400 to 420 milligrams and 310 to 360 milligrams for women. Magnesium serum level is not an effective measure since only less than 1% is found in the serum. So if we want to get levels, we have to take the RBC magnesium or the ionized magnesium. Formulation of magnesium supplements affects absorption and bioavailability, and it has been shown that magnesium citrate, aspartate, lactate, and chloride are better absorbed than magnesium oxide and magnesium sulfate. Zinc also in high doses can interfere with absorption. So probably it's better not to take them together. And as you know, a lot of people are taking zinc right now, no, for the prevention of COVID. What is the exact role of magnesium in migraine? Okay. Magnesium, like zinc, is an anti-NMDA receptor antagonist and it influences mitochondrial metabolism. Multiple studies have shown that patients with migraine have low levels of magnesium. In the US, nearly 50% of Americans have a magnesium deficient diet. Even if our body contains magnesium, we have to take supplements if we want to use this for migraine prophylaxis. Other drugs may also reduce magnesium absorption, such as proton pump inhibitors, and caffeine, alcohol, and stress can increase magnesium excretion. One of the main roles of magnesium is to conserve neurons' electrical potential. Magnesium is the physiological antagonist at the NMDA channel, which is involved in the regulation of neuronal excitability. It is necessary for the proper functioning of several ATPases, your sodium potassium ATPase, which controls the sodium pump. It also has a powerful membrane stabilizing property that are important for the insertion of proteins and the formation of phospholipids. Thus, if you have magnesium deficiency, this could induce platelet aggregation and glutamate release. It can also promote the release of your 5-hydroxytryptamine and induce vasoconstriction. It can promote cortical spreading depression, and it can generate and release of substance P, which is believed to act on the sensory fibers and produce headache pain. So all of these are involved in migraine pathophysiology. So if we have extra magnesium, it can help prevent migraines by blocking the calcium channels and the NMDA receptors. It may also block the synthesis, the release, and activity of your glutamate, which promotes entry of calcium that excites the neuron and produces vasoconstriction. And it may block the synthesis and release of your nitric oxide that causes also vasodilatation. So here are the three RCTs on migraine, on magnesium for migraine prophylaxis. The first study is by Pickert, wherein there were 81 patients aged 18 to 65 years diagnosed with migraine and randomized in a prospective multicenter, placebo-controlled and double-blind randomized study to either oral trimagnesium dicitrate at 600 milligrams daily for 12 weeks versus placebo. At week 9 to 12, attacks have decreased by 41.6% in the magnesium group versus 15.8% only in the placebo group. There was a decrease in the migraine days and decrease in the drug use for symptomatic treatment. The overall responder rate was 53% versus 34% for placebo, and adverse events reported were diarrhea and gastric irritation. The next study is another double-blind placebo-controlled study by Pfaffenroth, wherein 69 patients age 18 to 64 years old were randomized to receive magnesium aspartate at 243 milligrams BID versus placebo for 12 weeks. The calculated sample actually here was 150, but they decided to do an interim analysis with 60 patients. So when they reached 69 patients, they made an analysis and it showed no benefit in terms of the number of migraine days and migraine attacks. 46% even developed soft stools and diarrhea. The last double-blind randomized placebo-controlled study is by Koshoglu, wherein they randomized 30 patients with migraine with aura without aura, aged 20 to 55 years old, and they were given magnesium citrate at 600 milligrams per day versus placebo. This study showed a decrease in the migraine attack frequency, severity, as well as the improvement in the P1 amplitude in the visual evoked response of these patients. So, in summary, these three studies show that patients given magnesium citrate at 600 milligrams per day showed significant decrease in the migraine frequency, intensity, and duration, and also decrease in the drug used for acute symptomatic treatment. However, the study by Pfaffenroth, which used magnesium aspartate at 250 milligrams BID, did not show any positive effect. The common side effects for all of these studies showed soft stools and diarrhea. Another recent study, which I included here, is the combination therapy of valproate and magnesium. So a randomized single-center double-blind parallel group controlled clinical trial was done comparing three groups. Group A was on sodium valproate alone, Group B was on magnesium with sodium valproate, and Group C was given magnesium alone. So this result showed a significant reduction in all migraine characteristics in the frequency, severity, and intensity, and intergroup analysis showed that there was no statistically significant difference in the headache frequency between groups A and B, but there was a significant reduction in group B for the other parameters. So this suggests that magnesium can enhance the anti-migraine properties of sodium valproate in combination therapy. So the recommendations for magnesium by the AAN, AHS is level B, probably effective and should be considered for migraine prevention. For the Canadian Headache Society, they gave a strong recommendation with low quality evidence. And for the EFNS, they gave the level C recommendation. And they recommend that this can be used as a third choice prophylactic agent. Now we go to riboflavin, which is vitamin B2. It can be sourced from milk, meat, eggs, nuts, enriched flour, and green vegetables. And it is involved in the development of skin, lining of the digestive tract, red blood cells, and even brain function. The RDA for riboflavin is only 1.1 milligram per day for women and 1.3 milligram per day for men. It is required for mitochondrial function, and riboflavin is essential to the formation of two major enzymes, or flavin mononucleotide and flavin adenine dinucleotide, which is involved in the electron transport chain of your Krebs cycle. So these coenzymes are involved in energy metabolism, cellular respiration, and antibody production, as well as growth and development. It is essential for the metabolism of your carbohydrates, proteins, and fats. There is one RCT of riboflavin versus placebo, and the AAN AHS gave them level B evidence. So this is the study by Shonen comparing riboflavin 400 milligrams per day versus placebo in 55 patients with migraine on a 3-month duration of the above treatment. Using an intention to treat analysis, riboflavin was superior to placebo in reducing attack frequency and headache days for patients on riboflavin. Patients had 2 fewer attacks per month compared to no change in the placebo group. The proportion of patients who improved by at least 50% decrease in migraine frequency was 15% only for placebo and 59% for riboflavin, and the number needed to treat for effectiveness was 2.3. 2 minor adverse reactions were reported, and these were diarrhea and polyuria. Riboflavin has been also conducted in a placebo-controlled study among children, but studies were inconclusive. But for adolescents, this study by Athaila was done in Indonesia, and a total of 98 adolescents aged 12 to 19 years were included in this study. They were divided into two groups. One group received 400 milligrams of riboflavin, and the other group received placebo for 3 months. This study showed that there was a significant decrease in the headache frequency, headache duration, and even in the disability measured by the PEDMIDA scores. Adverse events reported were polyuria and diarrhea. So in the adult study, patients who received riboflavin at 400 milligrams per day had significant reduction in headache frequency and headache days, with a higher responder rate for those with 50% reduction in migraine frequency. In the study among adolescents, there was also significant response with riboflavin at the same dose in terms of decreased headache frequency, decreased headache duration, and decreased disability. Adverse events were similar, polyuria and diarrhea for both studies. Riboflavin was given a level B recommendation by the AAN and the AHS, and the Canadian Headache Society also gave it a strong recommendation with low quality evidence, and the EFNS also gave it a level C recommendation. The last topic that we will be discussing is the coenzyme Q10, which is important for mitochondrial function, and it is also a very well-known antioxidant. It is known as ubiquinone and is a key factor in mitochondrial electron transport chain, and it may have a role in migraine properties owing to its antioxidant and anti-inflammatory properties. An NIH-funded study showed that it didn't improve in other neurologic diseases like Parkinson's disease, but it is also being studied in other conditions like ALS, Down syndrome, Huntington's disease, and others. Later, I will be discussing two RCTs of coenzyme Q10 for migraine preventive, and the AAN, AHS also gave it a level C recommendation, which is quite lower than riboflavin and magnesium. So the first study is by Sandor, which is a double-blind, randomized, two parallel group trial, including patients 18 to 65 years diagnosed with migraine. They were randomized to the group receiving 100 milligrams of CoQ10 at 3 times a day versus placebo for 3 months. 43 patients were randomized in the study, and the headache frequency was decreased in the CoQ10 group. There was also a 50% responder rate for headache frequency in patients in the CoQ10 group. For severity, mean duration, and acute medication use, however, the groups did not differ. In the CoQ10 group, one patient withdrew because of cutaneous allergy. The other study is by Dari in 2017. CoQ10 was studied not only in terms of its effect on the clinical features of migraine, but also on its effect on inflammatory markers. So this is So this is a randomized, double-blind, placebo-controlled add-on trial. So this is a study by Dari, wherein there is 84 patients were randomized into a CoQ10 group. They were given 200 milligrams 2 times a day, or a total of 400 milligrams per day versus placebo for 12 weeks. And again, it showed a reduction in the frequency of migraine attacks, and also an increased responder rate response compared to the placebo group. In this study, there were no side effects noted. The next study is a meta-analysis of coenzyme Q10 as a supplement for migraine prophylaxis. So this systematic review and meta-analysis objective was to determine the effects of CoQ10 for the reduction in the severity, frequency of migraine attacks, and duration of headache in adult patients with migraine. Data sources included Cochrane, Central Medline, Embase, and others. And the search was done until journals published in December of 2019. Only RCTs were included in this meta-analysis. Crossover designs and controlled clinical trials were excluded. So in total, there were 6 studies with a total of 371 participants included. CoQ10 supplementation was shown to reduce the duration of headache attacks and reduce the frequency of migraine headaches compared to the control group. However, there is no statistically significant reduction in the severity or intensity of the migraine. So they concluded that CoQ10 appears to have beneficial effects in reducing the duration and the frequency of migraine attacks in patients taking CoQ10. So, in summary, for CoQ10, the first study of Sanders showed that there was a decrease in headache frequency, but no difference in the severity, mean duration, and acute medication use. But in the study by Dari, there was a significant response in all parameters in the migraine frequency, severity, and duration of the migraine attacks. And as you can see, they gave 400 milligrams of CoQ10 compared to Sander, wherein they gave 300 milligrams. Moreover, the study by Dari also showed that there was a decrease in the pro-inflammatory markers, specifically your CGRP and your TNF alpha, but there was no change in the levels of interleukin 6 and interleukin 10. The meta-analysis also showed that there was a decrease in the frequency and duration of migraine attacks. So CoQ10 received the level C recommendation from the AAN and the AHS, and the Canadian Headache Society gave it also a strong recommendation in spite of low quality evidence, and the EFNS gave it a level C recommendation. So this is the tally of the recommendations of the different societies for the 3 molecules. So for AAN, magnesium received a level B recommendation, as well as riboflavin, and CoQ10 received a level C of recommendation. But for the Canadian Headache Society, they gave a similar recommendation for all the 3 molecules, and the EFNS also gave a level C recommendation for all the 3 molecules. So knowing all the benefits that we get from each of these nutraceutical, can the effect of these 3 molecules be additive? No? So this is a study by Gold, Diner, and Danish, wherein they compared the effect of giving riboflavin, magnesium, and CoQ10 in one pill versus placebo. So actually, this is from the Migravent study group. Migravent is the drug that they are using in Germany, and it is being given at 2 capsules BID for a total of 400 milligrams of riboflavin, 600 milligrams of magnesium, and 150 milligrams per day of coenzyme Q. And aside from this high dose of these 3 molecules, it also contains low dose other multivitamins. Migravent is also being marketed in the US as Dolovent, and with the same content, with the same milligrams. So this is a randomized double-blind study comparing Migravent with placebo, and 130 subjects were included, aged 18 to 65 years. They were randomized into 2 groups, the Migravent versus placebo, for 3 months, following a 4-week baseline washout period. So they made sure that the patient was not on any prophylactic medication for at least 1 month prior to the inclusion in the study. So results show that migraine days per month declined from 6.2 to 4.4 days compared with baseline. The intensity of migraine pain was significantly reduced in the supplement group, and the sum score of the HIT questionnaire was reduced by 4.8 points. That is from 61.9 to 57.1 points. Treatment with a supplement containing magnesium, riboflavin, and coenzyme Q10 had an impact on migraine frequency, which showed a trend towards statistical significance. Migraine symptoms and burden of the disease, however, were statistically significant reduced compared to placebo in patients with migraine attacks. So, when should nutraceuticals be used? We must consider this in patients without marked disability and who are trying prophylaxis for the first time. We may also use this for patients who want to avoid the side effects of the more common prophylactic agents for migraine and patients who have intolerable side effects on acute treatment and also prophylactic medications, and it may be used as a baseline to which drug prophylactics can be added if necessary. There is evidence to support the use of several nutraceuticals for migraine prevention, although the evidence may be modest, as has been shown in the previous studies. The amount of benefit with nutraceuticals may be modest also for most patients, but it may be worth trying, especially in patients who cannot tolerate side effects and who do not want to take drugs for their migraine as a maintenance as a maintenance basis. So I hope that you also have learned a lot, just like me when I was preparing for this lecture for the role of nutraceuticals in migraine prophylaxis, which can be given as an initial therapy or an add-on therapy for the more common prophylactic agents for migraine prophylaxis. Thank you.